Hello, my name is John Tsai, and I'm one of the nephrologists here at UCI. In this video, we will continue our exploration of renal physiology with discussing potassium regulation in the kidneys. As a reminder, this is a part of a series of lectures exploring the different physiological aspects of the kidney. We have already discussed how the kidney handles sodium and water. In this video, we will be talking about potassium regulation, the second most abundant electrolyte in our body. And in the next video, we will be delving into how our kidneys regulate the acid that is produced in our body. Lastly, we'll be wrapping up with a video recapping and synthesizing the hormonal aspects of the kidney. Let's first talk about where potassium is reabsorbed or secreted in the kidney. Like sodium, potassium is freely filtered through the glomerulus, and most potassium is reabsorbed in the proximal convoluted tubule. This secretion absorbs about 65 to 70% of the filtered potassium load by a solvent drag when water is reabsorbed. As we progress through the nephron, an additional 20% of the potassium in the filtrate is then reabsorbed in the thick ascending limb of the loop of Henle through our friend, the potassium sodium 2-chloride transporter, the same one that is blocked by loop diuretics. Lastly, the distal tubule is then responsible for either reabsorbing potassium or secreting potassium, depending upon the hormone aldosterone in response to either low or high potassium levels in the body. While our kidneys are inherently designed to reabsorb sodium, regulation of potassium is slightly different in that instead of only controlling how much we reabsorb, as in the case of sodium, we actually have the ability to excrete any excess potassium that we don't need. Perhaps it is because small fluctuations in potassium can lead to deleterious consequences for organs, which is not the same when it comes to sodium. Additionally, our other cells in the body have the ability to help regulate intravascular potassium levels in order to help maintain normal potassium levels or normokalemia, and we will be discussing this later on in this talk as well. For another in-depth review of this, you can visit the Deranged Physiology website I have listed here as an additional material to review. Now let's delve into the details of how our kidneys deal with low and high potassium states. In low potassium states, our distal tubule acts to reabsorb as much potassium as possible from a filtrate through the activity of the hydrogen potassium ADPase. In this situation, aldosterone is also turned off in response to low potassium stores, and we will discuss the importance of aldosterone in the next slide. Now, what about high potassium states? In this scenario, we don't want to be reabsorbing potassium, and we want to be getting rid of any extra potassium in our body. The action of this is primarily led by the hormone aldosterone. In high potassium states, aldosterone activity is elevated, which leads to activation of the epithelial sodium channel, or ENaC. This is the same ENaC channel that we discussed in the sodium regulation talk. Now, in addition to reabsorbing one sodium molecule, the principal cell has to get rid of a cation in order to maintain electron neutrality, and this is done through the ROMK channel, or renal outer medullary potassium channel. Additionally, there's a maxi-K channel that also allows for potassium to be bumped out of the principal cell. The activity of the maxi-K channel is thought to be mediated by angiotensin II, but the magnitude that potassium is regulated through this channel is unclear, with the aldosterone-mediated ENaC and ROMK pathway being likely the more dominant and the one you should remember. Because maintaining normal potassium levels is so important in our body, we have other mechanisms which work to precisely regulate the potassium concentration in our serum for optimal organ functioning. The muscles are the other major player for potassium regulation in our body, aside from our kidney. Through activation of the beta-adrenergic receptors as well as insulin receptors, both of these result in higher uptake of potassium through the sodium-potassium ATPase activity shown at the top of this figure. This ultimately results in lower serum potassium levels until our kidneys are able to eliminate that excess potassium from our body. These 2 points of potassium regulation are very important avenues that we can use to therapeutically reduce a patient's potassium level quickly and effectively in the setting of hyperkalemia. Finally, in the setting of abnormal acid-base disturbances in our body, our cells can help regulate our acid-base status at the expense of potassium. This is seen here in these two diagrams. On the left, hydrogen ions in the setting of acidosis for whatever reason results in hydrogen ions shifting into the cells. To maintain electroneutrality, a potassium ion is excreted at the same time. This results in assisting with preventing severe acidotic states in the blood, but this also results in a potentially higher potassium level in the blood, or hyperkalemia. Hence, we typically see acidosis and hyperkalemia hand in hand in clinical practice. On the right diagram, we see that the opposite happens in alkalotic states. Hydrogen ions are excreted to help maintain our pH balance, but this is at the expense of potassium shifting back into cells. So we also see hypokalemia with alkalosis in the clinical setting, but this is usually rare compared to the hyperkalemia and acidosis combination that we see on the left. Now, we can use this property to help us treat abnormally high potassium levels, or hyperkalemia. If we want to get potassium to shift into cells, we increase the pH of the blood, which will then result in hydrogen ions coming out of the cells, but also potassium entering into the cells. We do this by giving patients sodium bicarbonate, which increases the pH of the blood and helps drive potassium cells into the cells as a byproduct of hydrogen ions shifting out of the cells to neutralize the sodium bicarbonate that we are artificially providing to the patient. Now let's summarize what we have learned about potassium regulation by talking about potassium-sparing diuretics. There are generally two classes of potassium-sparing diuretics that we use. The first are called mineralocorticoid receptor antagonists, or MRAs, and the other class are epithelial sodium channel antagonists, or ENaC antagonists. Mineralocorticoid receptor antagonists prevent the action of aldosterone from binding to the mineralocorticoid receptor, which then prevents translocation of the epithelial sodium channel, or ENaC, to the luminal membrane. Because it prevents ENaC from being active, this results in sodium bypassing the cortical collecting duct, subsequently resulting in a diuretic effect. Remember, where sodium goes, water follows. Similarly, if we directly block the epithelial sodium channel with a medication, the result is the same because sodium molecules will bypass the cortical collecting duct and be wasted. Because of the lack of ENaC and distal sodium delivery, both classes of medications also have the side effect of potassium retention, which can lead to high potassium levels or hyperkalemia. Why use one versus the other? MRAs, or mineralocorticoid receptor antagonists, have other pleiotropic effects around the body that potentially offer other effects, while medications that directly block the ENaC channel don't have these effects other than its diuretic effect. In fact, MRAs have been shown to help remodel our kidney after injury and prevent proteinuria. Additionally, they have also been shown to have good effects in heart failure and diabetic kidney disease outcomes, which you will likely learn about more in your pathophysiology courses. Lastly, I'll leave you with a question to test your understanding of the material we have presented so far today. Fludrocortisone, or Florinef, is used for the treatment of adrenal insufficiency, a condition where you're not able to produce aldosterone. Knowing that this medication activates the mineralocorticoid receptor similar to aldosterone, what is the expected effect on sodium and potassium regulation in the kidney? Pause the video here to think about this, and continue on the next slide when you have your answer. The two side effects that we expect are sodium retention and potassium wasting. Fludrocortisone attaches to the mineralocorticoid receptor as well as aldosterone does, and essentially performs the same functions, namely enhancing ENaC translocation to the luminal side. This results in sodium retention, which can lead to high blood pressure, and potassium wasting due to the increase in sodium reabsorption, with a potassium molecule being excreted through the ROMK channel. Thanks for joining me today on this video on understanding potassium handling in the kidneys and how we also regulate potassium in our blood through shifting into other cells, especially our muscle cells. Here are some other great resources to help solidify your knowledge of renal potassium handling that you can review. In our next video, we will be discussing how our kidneys handle acid and maintain a normal pH in our body.